If all of us work together, there's a nursing shortage. And between Gaston College, between the Abbey and the BS, and between Caramont and clinical and all work, we have an opportunity to sustain and grow Gaston County. And the function of this is to give scholarships to Gaston County students. I say that again, Gaston County students. And is to provide opportunities to grow the BS degree, that it can be an educator, possibly over at Gaston College, and so that we can bring more people into the nursing career. I have Dr. Scott Centers here this evening, and he started on a different route into the medical field, and I think that needs to be looked at as well, because we need all hands, and when we're looking at tomorrow. So what I would like to do is turn it over right now to Bill Gross, who will be the MC for the evening for our panelists. Thank you.
Good evening, and thank you for your comments, Whitney. Whitney is far too humble to say he's the driving force behind this program, but he is. With his leadership, the college will hold this event annually. And we thank you, Whitney, and Belmont Abbey College, and we thank all of you for joining us this evening. My name is William Gross, and I spent the bulk of my career with the Gaston County Health Department and served as staff to the Gaston Controlled Substances Coalition from 2016 to 2023. In those 7 years, we worked to educate Gaston County residents about opioid use disorder and its causes, and to promote the proper use of Narcan, the drug that reverses or can reverse overdoses of opioids. Critically, we also work to remove stigma about opioids, because this attitude is the largest barrier to our defeating this scourge. While our community has made great strides, opioids remain a local crisis. Our situation reminds me of a 1977 monograph entitled "Doing Better and Feeling Worse." It was a story of the American healthcare system. That's our situation today with opioids as well. In truth, our opioid epidemic is deeply complex and solutions are elusive. It requires community organizations to collaborate and to employ multi-pronged approaches, which means we must break the silos that inhibit cooperation between and within organizations. That also means we must all do our share, because no single organization or person can solve this problem. To help us with this task, we have convened an outstanding group of speakers who will work to engage your heads, your hearts, and your hands. It is our goal for you to leave this session with better understandings, with insights into harm reduction, with questions, and a commitment to finding answers to your questions at school, at work, and on your own, and from our panelists at the end of the program. To get us started, our first speaker is Michelle Mathis. Michelle is the chair of the Gaston Controlled Substances Coalition, and she is the director of Olive Branch Ministry. With 3 minutes to go, I will notify each of our speakers, so if you hear me whispering in the background, it's okay. Michelle.
I love Bill, but I don't always listen to him, so I have my own timer. Bill and I have worked together for a long time. I want to thank Whitney, I want to thank Bill for the introductions this evening and for gathering us here. And I want to thank the college for opening up space and being willing to talk about the tough things. So with that, I'll say good evening. And thank you to you for gathering here this evening to discuss the most pressing issues facing our communities, the overdose crisis. This crisis has left families shattered, communities grieving, and far too many lives cut short. In 2023, North Carolina had 4,156 suspected overdose deaths. In 2024, that number decreased by 27% to 3,025. And while one death is too many, I must find hope in progress. The speakers after me will share more specific local data according to their expertise. But I can tell you that we have seen a significant decrease in ED overdose visits and overdose deaths in Gaston County in the past 2 years as well. And again, this gives me hope. Hope rooted in compassion and understanding and the principles of harm reduction that are being implemented throughout our community. And if you are not familiar with the term harm reduction now, I'm going to give you some program examples that are happening throughout the county. But in short, it is simply reducing harm by implementing strategies for individuals who engage in high-risk behavior. It's not enabling high-risk behavior. It is, in fact, saving lives. Harm reduction is an evidence-based program and philosophy that was implemented in the 80s in the UK as a result of the HIV outbreak and AIDS epidemic. We now have harm reduction, whether legal or underground, in all 50 states, and a robust program in Puerto Rico. In North Carolina, we have about 60 designated harm reduction specific agencies, but more importantly, we see in our communities other agencies, other service providers, universities, colleges, law enforcement agencies, churches, communities of faith that are also embracing harm reduction. And I want to talk to you about that. When we think about substance use disorder and addiction, we often frame it as a battle, a fight against something. But what if we flipped that narrative? What if we realized that love fights alongside, not against addiction? Addiction isn't a moral failing. It's a complex issue rooted in pain and trauma and often isolation. And if we want to truly make a difference, we must meet people where they are, not where we want them to be. This approach is not about condoning substance use, let me be clear. It is about recognizing the humanity of each person and ensuring their safety, no matter where they are on their journey. Because, let me be clear, providing care isn't a gateway to substance use. It is a gateway to safety. Think about it. When we distribute naloxone or Narcan, clean syringes, or fentanyl test strips, we are not enabling addiction. We're preventing death. We're creating space for people to survive long enough to consider positive change. Waiting for someone to hit rock bottom in the hopes that they will seek traditional recovery paths is actually wishing harm on them. If someone in their active substance use is here and we say we want them to hit rock bottom, we are actually wishing harm on them. Whereas we could change our attitudes, our mindsets, and our vocabulary and instead meet them where they are and continue to lift them up. Isn't it better to hold space with them and provide non-judgmental love and support while providing alternatives that lead to healthier outcomes? At the heart of it all, love is the most powerful tool we have in supporting someone struggling with substances. Here in Gaston County, we must strengthen harm reduction programming in recovery and support agencies and encourage connection. Why? Because isolation doesn't just hurt, it kills. It deepens struggles and makes recovery seem impossible. People need safe spaces and supportive communities where they can start to heal. For example, programs like peer support groups and syringe exchange services have shown remarkable success in reducing overdose rates and increasing engagement in recovery services. Now I want to highlight a few existing programs that are using harm reduction to make positive changes in Gaston County. Gaston Together is an agency that provides naloxone training, and Gaston County residents and organizations can learn through their educational program how to recognize opioid overdose symptoms. They can understand opioids' effects and why naloxone works. They can commit to preventing opioid deaths. They learn how to effectively use naloxone and how to properly dispose of unused medicine. To date, Gaston Together has shared this information with over 600 people, from teen groups to senior citizens, government, businesses, and nonprofit organizations. In addition to the naloxone and overdose prevention education program, Gaston Together provides a Just Call program, which was originally created to encourage college students to call for help during overdoses and other emergencies. As the program developed, they also added mental health and substance use disorder resources to the information that is shared. After discovering a need for additional groups to have this information, Gaston Together expanded the program to all ages. The goal of the program is simple. If anyone is in a situation where they are asked, should I call for help or should I call 911, we want them to remember the training and say, just call. You might save their life. Gaston Emergency Services deserves a highlight through their community paramedic program. And I'll give you the specifics for that, but let me just say, Olive Branch, the faith-based harm reduction agency that I run in Gaston County, partnered originally with GEMS back in 2018. And we began an overdose response team with funding from Partners Behavioral Health. It took us a while to get going, to build trust within the community, but then we began receiving calls from not just the hospital or not just people who themselves had overdosed, but we began receiving calls from employers. And we had employers who would say, can you help my employee who is in crisis? And this is all part of harm reduction. And from that fledgling relationship, we know now that in 2024, the Gaston County EMS Community Paramedic Program has made significant strides in combating the opioid crisis. They supported 69 inductions through their field medication-assisted treatment program. They reached approximately 123 patients through their new jail-based program and expanded community opioid education efforts to increase awareness and prevention. Additionally, GEMS enhanced naloxone distribution, access to fentanyl and xylazine test strips, empowering individuals to stay safe. These initiatives contributed to a remarkable 40% decrease in opioid overdoses compared to 2023, showcasing GEMS' dedication to saving lives and addressing substance use disorder in Gaston County. All of these GEMS programs not only involve community paramedics, but also harm reduction trained North Carolina certified peer support specialists. These are individuals who have lived experience with substance use disorder, who are in recovery and use their training and their own experience to assist others in active use to find pathways to positive change. Gaston County Child and Family Services contracted with, using opioid settlement dollars in 2024 to embed peer support in their departments to work with families affected by substance use. One peer works with families working for reunification who are involved in the court system, and the other peer works with families who are seeking assistance so their family can avoid court involvement. Several individuals have been linked to and completed rehabilitation programs through this partnership. Several have found permanent housing and/or employment, and children have been reunited with their families and are receiving ongoing peer support. The Gaston LEAD program, and let me tell you, LEAD stands for Law Enforcement Assisted Diversion, is a voluntary pre-arrest diversion program developed with the community that allows law enforcement to redirect eligible low-level offenders to community-based programs and services instead of jail and prosecution. By diverting eligible individuals to services, LEAD is committed to reducing drug use, improving public safety and public health, and reducing recidivism. Adults residing in Gaston County whose criminal justice involvement stems from problematic substance use, mental illness, poverty, and/or homelessness, and who have barriers to accessing assistance through traditional social service programs. LEAD provides long-term, client-directive, non-coercive, street-based case management based on harm reduction principles. Case managers, some of whom are in the room tonight, frequently with LEAD participants to build trust and develop goals, which are expected to change over time. LEAD also employs peer support specialists because we know that people with lived experience are the subject matter experts and best suited to help those living the experience. The Gaston County Police Department partners with the Gaston County District Attorney's Office, Gaston Together, local treatment providers, and various nonprofits and community organizations. And the LEAD program is housed under Gaston County Police Department. Other Gaston County departments and standalone agencies are also utilizing harm reduction principles in both their policies and their programs. The list could go on, and I'm sure many of you are here in the room tonight. But positive change through harm reduction is not just about programs. It's also about how we treat people. There's no good in having programs if we create barriers to engagement. Reducing stigma is key to successful engagement. Imagine struggling with addiction and being told either implicitly or explicitly that your life is worthless because of your substance use. We must remind everyone that their value is not tied to their substance use, that every person deserves dignity and care. Changing our language can be a key element to treating people with respect and removing barriers to engagement. When you have a conversation with someone, the words you use matter. I often say when I'm speaking with faith communities that God said, "Let there be light," and there was light. So too it is with us. Our words create a world that relationship is going to live in for its existence. And you have, by the words that you choose, the ability to create safe space and create a welcoming environment, or to create some place where someone experiences trauma and fear and trepidation. At Olive Branch, we do not use words like addict and clean and dirty and relapse. These terms are stigmatizing, demoralizing, and dehumanizing. Our language can be a tremendous barrier to engaging people in care. I've been doing harm reduction for well over 20 years in one form of fashion or the other. And in all this time, I've never met an addict. I simply meet people. People who have names and life stories and challenges that may or may not be different from my own. We share the same Creator and are loved and valued equally. And if God calls them by name, who am I to call them anything different? As we engage, we must also respect their autonomy. Offer support, but remember that it's their journey and their choices to make. Forcing someone into recovery might seem like a quick fix, but it dismisses their humanity. It's support, not coercion, that fosters change. So what does this look like in practice? As I said earlier, first we meet them where they are. We avoid pushing for immediate change. Sometimes when you engage someone, they are ready to make a change at that moment. And if it is their decision, we celebrate that and we do everything we can to link them to the appropriate resources. But remember, they're in the driver's seat. You're along for the ride. We can focus on supporting what their current needs are. And maybe it's connecting them with safe space to sleep. Maybe it's a clean needle. Maybe it's just a conversation. And sometimes the most powerful thing that we can do is the most simple. Check in and do it often. In fact, when I leave here tonight, one of my buddies works at a late night spot. I'm going to swing by and just check on them because I haven't seen them in a couple of weeks. That check-in lets them know that even when they're not in your presence, that they're on your mind and that you truly care about who they are and not just what they want or need when they're standing in front of you. You can ask people, how are you doing? And then be prepared for the answer. A lot of times at the grocery store, when the checkout person, how many people still go to the grocery store? I guess I should ask. I don't go that often, but when I'm there and they ask me, how are you doing? How's your day? I give an honest answer. And a lot of times people's faces get kind of screwed up because when you get an honest answer and you've asked the question, then we feel obligated to address any needs that are there. But I encourage you to be brave. Ask the question, how are you doing? But be prepared to assist if you can. Sometimes that's all someone needs to feel seen, to feel human, to feel wanted, and to feel valued. In the story of the Good Samaritan, we are taught what it means to love our neighbor. The Samaritan didn't ask the man how he got where he was. He didn't lecture him about his choices. He simply stopped, met him where he was, and cared for his immediate needs. And because he had other things that he needed to do, he linked that person to care for people that were able to meet needs beyond what he could. And that's what we're getting pretty good at in Gaston County. It's taken us a while to get there, to break down those silos, but we're doing it. Love fights alongside, not against addiction. This is more than an individual action. It's about creating a culture, a community where people feel valued and safe. Everyone deserves a community that values their safety and their story. When I was asked to consider taking over the chair of the Gaston Controlled Substance Coalition, I remember where I was when I got that call from Chief Ramey in the back. Good to see you, sir. And one of the questions I ask are we going to continue embracing harm reduction? Because I don't know how to do this any other way. And he said he pretty much, I'm paraphrasing, he wouldn't have it any other way. Through the coalition, we have begun to break down silos between providers. We see where services are being duplicated. We see how we can shore each other up. We talk to each other on a pretty regular basis. And we're making great strides in this community, as evidenced by the numbers I mentioned earlier, and hopefully the numbers that we will hear a little bit later on. What I've shared isn't just about the individual efforts, like I said. It's about creating this community, right? It's about recognizing that recovery is more than just treatment. Abstinence is no longer the gold star standard for everyone. Recovery is a continuum. It is self-defined. It looks different for each person. Recovery is about building relationships, fostering trust, and creating an environment where healing is possible. So for those of you who are here this evening, I want to challenge all of us to take action. Advocate for expanded access to harm reduction focused programming and partnerships. like overdose prevention, syringe access, naloxone distribution, medication-assisted treatment. Support local initiatives to create safe spaces for individuals to connect and heal. Reduce stigma in your own conversations and actions, and remind those around you that every life has value. The Gas and Controlled Substances Coalition is committed to building a culture of compassion, one where love and care and understanding guide our actions as community partners and treatment providers, because everyone deserves a community that values them. The overdose crisis is daunting, but it's not insurmountable. Together, we can save lives. We can create a world where fewer families grieve, where more people find hope, and where love truly fights alongside addiction. Let us be the Good Samaritan of our time. Let us choose love over judgment, care over condemnation, and action over indifference. We can fight this together. You've proven that by being here this evening. You'll hear lots of great speakers after I sit down. The question is, what will you do with the information you've received? Will it go in one ear and out the other? Or will you truly take action? I have a tattoo on my arm that I wear proudly. It says acta non verba, actions, not words. Our words tonight mean nothing if we don't act. So as I sit down, think about how you can act once you leave here to save lives and to help end the opioid crisis and the overdose crisis in Gaston County. Thank you.
Before you bring Anthony up, let me speak. What? Before you bring Anthony up, let me speak.
Thank you, Michelle. Our next speaker is Dr. Scott Centers.
There may or may not be a presentation popping up there in a second. All right, well, thank you for having me. I'm Dr. Scott Centers. I'm the Medical Director for Emergency Services for Caremont Health. Can everybody hear me? I have a tendency to talk a little loud, so I was leaning back. So, I was invited to talk here a little bit. Michelle and I have interacted in the past many times. I tried to figure out what component of, crisis process, whatever label you want to put on this. It's a community epidemic, as we all know. But trying to figure out how I can kind of frame it from a hospital healthcare system perspective, because all of the pieces that Michelle referenced are all part of what it is that we accomplish. So I thought I'd kind of dive in with more of a granular piece to kind of share with people a little information, because we talk about it in very kind of broad strokes around the opioid crisis, but to frame it with some specifics. So if you can go to the next slide, unless there's a controller for me. All right. So this is a very busy slide, but hopefully everybody can see it. I think it's very important to frame perceptions in community about, we hear, fentanyl is all over the news, and we hear about the fentanyl issue and its permeation of the populace. But I don't know that everybody understands the ramifications of what fentanyl and some of the opioids are in the community. So I thought this slide really helped kind of frame the perspective of the relative strengths of medication. So, some of these are prescriptions, some of them are, in cough medicine, some of them are for pain, some of them. And so this is the way that a lot of people are introduced to these medications, right? They're through prescriptions, they're through, friends or whatnot, and they get introduced on the ones that are at the top of this scale. And then over time, the efficacy gets less and less, and they progress down the pathway with these medications, and unfortunately, end up, being exposed to fentanyl. And quite often, they're exposed to fentanyl not of their own volition. So they get introduced to it accidentally, and the first time they realize they've been exposed to fentanyl is when they wake up and I'm looking down at them on the gurney in the emergency room, and they're like, what happened? And because they thought they were taking one of the things that are higher up on the list there, and they actually got something that was laced or mixed with fentanyl. I think it's important to kind of grasp the concept up there, and the reference point is morphine. And if you've never had an opiate, morphine sounds, wow, it's a big, strong drug. It's actually the reference point for pain medicine in the hospital setting. So we basically would consider morphine a 1. And if morphine's a 1, fentanyl's 100. So if you kind of reference it from that perspective, we dose fentanyl in microgram dosings. And so that's in a controlled environment. Now imagine on the street, there's nobody there that's kind of parsing them out on what that dosage is and what's the safe dose or any of that kind of stuff. So I think it's important for us to kind of have a frame of reference as we kind of move forward. So you can move on to the next slide. And you can just kind of click through. I don't know why I thought I'd have a clicker. Yeah, you can use this one. That's perfect. So when the opioid epidemic really came front and center was when this bugger popped up in the community. Because as you reference up there, 100 times more powerful than fentanyl. So this is what kind of snuck its way into the system. And when you were seeing, the 2023 statistics where, you couldn't get on the news without seeing, there was a reference to overdoses. There were, drastic pictures in the news where you'd have, couples in their car outside of a shopping center that were overdosed in the parking lot. And, in the ERs, we were overwhelmed very often with the sheer number of folks that were coming in with overdoses. And we're equipped to handle those. In this scenario, we weren't necessarily equipped to handle them because Narcan didn't necessarily work on these folks right away. We had to give Narcan 3, 4, 5 times. We had to put them on Narcan drips in many cases in order to get them to revive. And so I tell you that because as a kind of a segue into the next slide, because what ends up happening is that, we think of these as, these drugs are so dangerous, I would never touch those drugs. And so what ends up happening though, and you can click to the next slide if you wouldn't mind. Quite often, things that we think are pretty benign, you get a Xanax from a friend or an Oxy from somebody, or you're buying it from somebody because you couldn't get a prescription and you have a chronic pain ailment. You think you're getting those medications, but quite often you're getting fentanyl pressed with residue of these other medications. And so I lost count of the number of times I've had somebody come into the emergency department and they may be a methamphetamine user or something like that, but they came in and they had to receive Narcan in order to be revived. And they're like, I didn't take fentanyl. I didn't take an opiate. Well, guess what? Yes, you did. You just didn't know where you were getting it from. So I spend as much time in these scenarios, beyond talking about detox and programs and stuff, it's safety. You have to know where you're getting these things from. Take me at face value. I don't want to see anything happen to you, and I'm going to try to educate you on, where are these medications coming from? Where are safe places to get them? And I can tell you, almost no place is safe to get them on the street anymore because they're mixed. And then one of the other things we hear are the synthetic cannabinoids as them being safe. Well, I mean, in their face value, they're relatively safe. They're synthetic, so you never really know exactly where these medications are coming from. But the challenge is they come in forms that can be mixed. So you're not just necessarily smoking it like a marijuana, like a joint or a marijuana cigarette. They're in tinctures, or they're in solutions, or they're in vapes, or they're in that stuff. And these things can also be mixed. Obviously, if you're getting it from a store, you're probably safer than some of the other things. But in the community, we're seeing more and more of these quote unquote safe drugs out there that are being mixed. So there's anywhere that there's a portal for this drug to be added is something that you have to be very concerned about. And, I would say in allied health, it's incumbent upon us to share that information to our friends that are not in healthcare, that are not in there. I can venture to say probably, without anybody raising hands, that pretty much everybody in this room has probably had a friend, family member, somebody that's been affected by the opioid crisis in some way, whether it's personally or a friend of a friend or somebody in that scenario. And that should just tell you, how extensive this is in the community. This isn't a inner city problem. This isn't a country problem. This isn't a suburban problem. This is an everywhere problem. Some of the worst places are as rural as you can get, where a lot of this stuff is going on, where you wouldn't think that they'd have any access to this stuff, but it's really just permeated everywhere. So, now that we're kind of at the end of the scared straight part of the talk, I figured we'd talk about what are we doing to kind of help combat some of this. So we, from a healthcare perspective, from a healthcare system perspective, we rely on our community partners in a lot of ways, but we actually felt, and Michelle alluded to this, that our partners at GEMS were light years ahead of us in how their community paramedic program, they're in the jail system now. I met with Brandon the other day, and we were talking about how many, they enrolled like 27 patients one day from the jail in the system to get into the MAT, medically assisted program. So it just shows you how, go where they are, meet people where they are in order to help, facilitate their journey, back. And so I bring all these folks into here because it starts with our teammates. We formulate the plan, we put these pieces together, and the medication, and we'll talk a little bit about the medications, are actually probably the smallest piece of the puzzle in all of this. They help stop the recidivism, but I think it's the community. We have our case management team does the outreach. So, we get to give you an example. So we have somebody that comes in, they've either been an overdose or they're seeking care. A lot of times people come in dual diagnosis. They have an addiction. They feel hopeless. They come in because they're having a mental health crisis. And the trigger or the cause of the mental health crisis is their inability to stop using the drugs. So we kind of try to touch both parts of that. So we activate our case management team and say, hey, we have somebody that we want to, get into the system. And when I say system, our system. So we actually have a protocol that gets initiated that triggers our case managers to get involved and our pharmacists. So we actually will dose them with Suboxone in the department, and in a little bit, we'll go over kind of the difference in some of the medicines that we have out there to introduce. But we'll initiate that process from a medication perspective, but also at the same time, we're reaching out, the case managers are calling the community paramedics, and the community paramedics have a service where they'll actually be like, oh, you have somebody in the ED right now that wants to get in and you're medicating, they'll actually come to the emergency room and do an intake interview with them in there. And they will actually follow them if they get to a point where we feel like they can be discharged. They will follow them. They will medicate them daily. They will go to their home in order to bridge them to outpatient, either to a primary care doctor that does addiction medicine, and there are a few out in the community in the Caremont system. We have Phoenix Crisis, which is out there. Kintegra has started introducing MAT certified providers there. So it really is a team approach to this, and it started in meeting people where they were and recognizing that this is where we were going to be able to make the most effect in the community, was being able to respond immediately. Because, for years you would find somebody be like, resuscitate them, and we'd be like, hey, are you interested in detox? And they would say yay or nay. And then we'd basically be like, right, here's your pamphlets. Maybe Michelle was going to come to the department and have one of the, the peer reviewers come in and somebody that had been there, and they would talk to them. But we didn't have the infrastructure around it like we do now in order to kind of present all the different opportunities to them. So I think we've made great progress. I think we're finally catching up to our peers in the pre-hospital and out of hospital setting to try to respond appropriately. You can go on to the next one if you would mind. So the difference, everybody hears about the medications that we use. The original medicine was methadone. The problem with methadone is it's a fairly potent opiate in and of itself. So folks a lot of times just kind of exchanged one addiction for another. It was controlled, so they weren't getting it necessarily off the street, so it kept them out of riskier situations, but it still was a situation where you were trading one addiction for the next. Where Suboxone has the ability to potentially stop the recidivism on that side. So there's two versions of this. So there's, and these are trade names, Subutex and Suboxone. Suboxone is the one we use most often because it has Narcan already mixed in with it. So, Suboxone or buprenorphine is a partial agonist. So basically it attaches to the same receptors that the opiates do. It just doesn't have as drastic an effect. So you get some of the benefit, some of the pain relief, some of the effect without the euphoria part of the opiate experience. And so that has a tendency to kind of blunt the self-defeating process of it. The Narcan piece, obviously, is the true antagonist. So if somebody has used recently or not in the appropriate phase, they can actually get precipitated withdrawal, which is not a fun process for them to go through. But sometimes it is a short-term necessary step. Now, the Subutex has no Narcan. It can be abused at higher doses. So most of the programs have a tendency to lean towards Suboxone in their usage, but we do have scenarios where we lean on the other ones moving forward. So there's, when I'm trying to frame this out from a global health perspective, and we'll see, I think the statistics bore out that, we hope that the decrease in the number of folks that have overdosed or had, whether it's deaths or overdoses and, just coming to the emergency department or having EMS respond because of an accidental overdose, those numbers are declining. We hope that it is because of programs like what we're working on. We know that we're better at responding to the acute event, but we don't want repeat events. We want them to be able to find recovery, find a new pathway. We're hoping also that the decrease in the fentanyl being accessible in the communities will also help some of that. So I think it's kind of a dual approach as we get farther into hospital systems and healthcare systems enabling that. And then again, that comes to the folks in this room. I think there's probably a good mix of folks that are, obviously there's nursing students in here. I was one of them many moons ago. My bachelor's is in nursing before I ended up going to medical school. And I'll talk a little bit about my journey to healthcare. But what we're doing with this program was kind of what drove me further in healthcare. So you can actually flip to the next slide if you wouldn't mind, and I'll. 5 minutes? Thanks, perfect. This is a perfect time to wrap up. So I think it's important to, because everybody comes from a different place, right? And so, my pathway to medicine and then ultimately emergency medicine was kind of the long and winding road. So I started out, all I wanted to do when I came out of high school was play football, went to Georgia Tech, figured out that I wasn't going to be a professional football player, and realized that I needed to kind of convert over to some more academic or scholarly pursuits. I started in engineering, really wasn't happy with engineering, and I really had no idea what I wanted to do. And so ultimately, I was paying for college myself, and I was like, I need to figure this out. So I was in the Army. So I went into the Army, and that's what you'll see, picture upper right. I was in overseas for a few years, and then came back, and I was getting the Army College Fund and the GI Bill, which helped me pay for college. But I ran into a friend of a friend who was a firefighter paramedic. And I was actually in the process of enrolling in college to go into management information systems, which is kind of the early phase of a lot of the early computer stuff. So I'm dating myself, but not everybody had a PC in their backpack back in the day. So it was a relatively new field. And I don't know whether I hate this guy or like this guy for changing my direction, because it turned out to be a pretty successful career. A lot of my friends did. But it really, he said, I can't see you sitting behind a desk. He goes, you look like somebody that, you need to take this EMT class. Go take this EMT class. So I took an EMT class over the summer, fell in love with it. Ultimately then got into paramedic school, and then started my career as a firefighter, which you can see up there. So I started a little later in life. As you can see, that's me with my, my two kids at the time as a firefighter paramedic. While doing that, and I'm telling you all this to kind of tell you that no matter what your background is, where you came from, what your challenges are, what you're doing at any given time, you can always change your direction, right? So, yeah, I love being a firefighter paramedic. I started teaching at the community college, the paramedic programs. I started going down to University of Miami. I'm from Fort Lauderdale originally. To University of Miami, and I used to teach ACLS to the med students. And I realized, man, they can do that. I could do that. You know, had the students in the classes with me, and then I went back to school. And so, at that phase, you know, I was married with kids, had a full-time job, and I wasn't sure if I was going to go to nurse anesthetist school or to medical school. I was kind of on the fence. So I got my bachelor's in nursing from Florida Atlantic University. Loved the program there, loved the faculty. They didn't talk to me for about 3 months after I told them I was going to med school, because they were a little bit mad at me for making the jump from nursing over to medicine. But then they got over it and showed me lots of love. But I went to med school. I started med school at 34. So again, reference point, this never too late. And I actually, shocker, was not the oldest person in my class. So there was actually a couple folks there in their upper 30s, early 40s that had careers, pharmacists, nurses, people that had done other things in the process. So a couple of the pictures up here, the bottom one, it was at a health fair that we used to do in Florida Keys all the time, and then the one above was graduation day from medical school with mom and the same two kids from the other picture over there. So I would encourage you, obviously for the students that are here, you're pursuing you're getting a likely, I'm assuming, a bachelor's degree in nursing, and you'll, at some point, I think most folks with the pressures of healthcare nowadays are going to get pushed into following one pathway or another in healthcare. I would encourage you to don't let time, age, or previous experience stop you from pursuing that thing that gives you the passion to do it, because at the end of the day, you'll get the opportunity that I have now, which is to make a difference, hopefully, not just on an individual basis with patients, but also in the community at large. All right, well, thank you very much. I appreciate your time.
Thank you, Dr. Sanders. Our next speaker is Tammy Chowdhury.
Good evening. First off, I would like to thank Whitney for inviting me to come back again this year and talk about my son, Austin. The story I'm going to tell is a true story, and it's the worst scenario in this opioid crisis. We lost Austin June 9th of 2017. He was just 24 years old. He just got his master's degree in urban planning. That was his passion, to make cities a bigger, better place with more parks, more green spaces, better transportation. He had a very big passion for that. I'm going to talk to you about how it started for him and how easy it could be any of us. For him, it started with a prescription of hydrocodone after he had a medical procedure. That was his first exposure to it. And shortly after that, I don't know, several months later, I found those unused portion of pills in his desk drawer. And I asked him if he had been taking them, and he admitted he had. And we talked about it, and I thought that was the end of it. He was young, he was a teenager. I figured kids try things, that was the end of it. But in reality, it was just the beginning of it. He started to use pills with some other kids at school. And eventually he was asked to leave school, not because he was caught using at school, but because rumors had gone around and the school didn't want anything to do with that. They didn't offer him, at that time, this was probably 2013, nobody was really talking about this. So they didn't want that to be associated with the school. So they offered nothing, no help, you do this, you do that, you can stay. And I imagine for him it was a pretty dramatic event because he was going to a private school and he had been there since he was in pre-K, and at this point he was in his junior year of high school. And when he left, he said it was embarrassing. I mean, he just never thought this was going to happen. As soon as we left, we took him to one of the biggest rehab places in Charlotte to be evaluated. And they evaluated him and they said that your son does not have an addiction. He's just experimenting. It's recreational. I think as parents, I think we made some big mistakes looking back at what happened because in my gut, I didn't feel like it was just recreational. And I should have questioned it. But I think as parents, sometimes I was more scared of him having to go away to a rehab. I just felt like we could handle this ourselves at home, which was totally wrong. So that was one of our mistakes, I feel like. I think as far as addiction goes, I think you need to nip it in the bud at the very beginning, and you got to do whatever you got to do, because once it goes to a certain point, it's really difficult to come back. People do, recovery is possible, but it's very difficult. And we like to think about our son, that if we would have been able to nip it in the bud at the first time, that he would still be alive, but we have no way of knowing that. I mean, we'd like to think that, but there's no way to know that. So after that, we also put him in counseling before he went to his new school for 6 weeks. And it was pretty much the same thing. I couldn't go there, we could not go there. It was just him and it was the counselor. What they discussed, I don't know, but my son was pretty smart, so I imagine he told them what they wanted to hear. He's pretty good at that. And at the very end, the last day, they brought me in and we all sat there together and they said, he says to me, I think he's going to be okay. I think it's just recreational again. Just keep an eye on him. So get this, it's just recreational. Just keep an eye on him. The next day, he goes to his new school, and we get a call that he was just arrested by the school resource officer for buying pills. I'm like, okay, he doesn't have a problem. So after that, he did well. He got his act together for the next couple of years. He was in the middle of his junior year. He took all AP courses. He did well on his exams, and he applied at different colleges. And in the end, he wanted to go to Chapel Hill because they had a good program that he was interested in there. And he had to do a lot to go there because he was arrested. So he had to write a lot of letters to people. He had to write letters to the university explaining what happened and what he did to change it. And he did all that. He wrote us a long letter apologizing for what he had put us through for the last couple years. And it just seemed like he was on the right track, and he was at the time. And he got into Chapel Hill. He went there in his undergrad. He seemed to be doing well. He'd come home and visit, and he looked good. He looked healthy. And then I guess talking to friends after we lost Austin, his third year of undergrad, they said he started doing pills again here and there. So, but we had no idea at that time that he had gone back to that. So he gets his degree, his undergrad degree. It was a happy day, and then it was time he needed to go get his master's. My husband and I, we just wanted him to get it all done and be done with it. Austin had said to us, he said, I would like to take a year off. I don't think Chapel Hill is probably the best place for me. And at the time, we were like, oh no, you're going to finish this. You're not taking a year off. What are you going to do? But again, I think as parents, we weren't listening to him. I think he was trying to tell us, it's not a good place for me. And it wasn't a good place for him. That's where he was getting his drugs. That's where his dealer was. And he knew that. He knew what was there, and we didn't listen. We just wanted him to go to school, get his degree, and this would be behind him. Things spiraled way out of control when he went to grad school. I think grad school can be a dangerous place, lonely place for a lot of people because your friends have moved on, they're working, they have jobs. He was the type of person who liked to be around people, and he was by himself. I had just recently spoke with one of his friends, and he told me, he said, you know, Austin was depressed. I said, what? Because I had talked to Austin many times and asked him, why are you doing this? Are you depressed? And he said, no, I'm not. I think at that time he was depressed in grad school because he was by himself. But again, we dropped the ball. It's hard for parents, I feel like, a lot of ways. You want to believe that your child is okay. Whatever he told us, we thought, looking back, we wanted to believe it so badly. We believed him and thought he was doing all the things that he needed to do. So he's in grad school and things are bad. He comes home to visit and he looks terrible. He lost a lot of weight. He would come home and he would steal money from us. And these are all things that you do when you're in addiction. You'll do anything to get the drug. And we would confront him about it, and he would always deny it. And I guess one time my parents were visiting, and he stole money from my mother. And I was shocked. And I was like, I know you took this from your grandmother. Why did you do this? I mean, I can't believe you would do that. You know, they don't have a lot of money. And he denied it. He flat out denied it. And then a couple days later, he put the money back. I was glad he put it back, but the day I confronted him, I went to his room one night when he came at home, and I said, I know you took this money from your grandmother, and I can't believe you did this. I said, you have got to get yourself together. And I remember talking to him, and I was just clueless. I can look back and just say I was clueless about everything. And he's sitting there, and I'm telling him this, and I'm looking at his hand shaking like this. And I'm thinking, I'm scaring him. I'm getting through to him this time. Finally, he's listening to me. That wasn't it at all. I'm sure he was under the influence or going through withdrawals, one of the two. The point of telling you all this is that as parents, we're clueless. I think at the time I thought I would know if my child had a problem or if he was doing these things. But I think you're in such denial sometimes. And I think in a lot of ways we were in denial. But he agreed to go to counseling when he went back to Chapel Hill, and he did. But I don't know if it did a lot of good. I even told him, I said, call me every day. I don't care. Call me every day if that'll help. And he says, yeah, that might help. I'll do that. And he did for a while. He called me every day. But honestly, when I look back on it, sometimes I would be talking to him, he would call me, and I couldn't understand anything he was saying. It was like he was under the influence. Again, I was in denial. So he gets his master's degree. He manages to get his master's degree. I don't know how, but he did. He was very smart. And a lot of people they do well for a while. And he did. And I thought, great. He came home. And I said, he's home now. We can watch him. He'll get a job. And this will just be over. That's how much I didn't know about addiction. So he came home, and it was obvious he was a mess. It was like dealing with a teenager again. I couldn't get him to get up in the morning. He was a mess. And one night he decides he says he's going out to meet his friends for dinner. And I'm like, okay, what can I do? He's an adult. This isn't a child. Even though I had a bad feeling about it. So he went, and it was a couple hours go by, and we hadn't heard from him, so we called him. And he said that he was watching a basketball game and he would be home. I said, okay. So it's getting very late. We go to bed, still no Austin. So we get a call about 1 in the morning, and he says that he was arrested, that he had just bought heroin and nodded off behind the wheel of his car. Mind you, at this time, that was how we learned he was doing heroin. We had no idea he was doing heroin. At that time, 2017, they started coming down on the prescribing, so you couldn't get pills cheap. So one pill was about $25, so heroin's $10 for a bag. So I'm sure his dealer said, try this, it's only $10, and it's better, and it's a lot better. There's no going back after you do that. And that's why when I say he came home, he was a mess. That's why he was a mess. Never seen this side of him before. So he had nodded off behind the wheel of his car, and I guess they had called the police, and the needle was there, and the heroin was there right on the seat of his car. So he just bought it and just took it. So he was arrested. So we went and got him, and we brought him home, and the next day we had to go to court, and we got his car, and we were planning what we were going to do with him, what we were trying to come. When we went to jail, my husband's talking to people in the jail, talking to all these parents. They're there for the same reason, and they've been dealing with it for years, and they're like talking about all these different programs, and some sounded like kind of crazy, but we knew we had to do something, so we were planning on doing something. And we came home, and the next day we had a trip planned to go see his brother in Ohio, and it was already planned, so we were going to go do that. So that night, Austin, we have a walkout basement. He was down there watching a basketball game, and we didn't know, he was on his phone. He had his phone, and he asked somebody to bring him drugs, and all he had to do was walk outside, and we had no idea. Because there were no drugs in the house. Believe me, I tore that house apart before we brought him home. But he got it like that. I guess we should have took his phone. But again, I'm dealing with an adult. I'm not dealing with a child. And so they brought it to him. And we didn't know. And so I was going to bed that night, and I said, Austin, I'm going to bed. Why don't you come up here and finish watching the game? And he says, yeah, I think I will. So he came up, and I started talking to him for a little bit, and it was strange because all of a sudden he's like in this really good mood, and he'd been in a really bad mood all day. And he's talking, and I'm like, wow, I wish he could be like this all the time. And I think he was just in a good mood because he knew what was waiting for him upstairs. So I go to bed, and he said he was going to watch the game. But my husband, when I went upstairs, I went into the restroom, I came out. My husband said, where's Austin? I said, he said he was going to watch the game. And he said, no, I heard him come upstairs. I looked down the hall, and I didn't see the light on him in his room. So I figured he just went to sleep. I wish I would have knocked on his door so badly, but I didn't. I didn't want to bother him. So the next morning, we're getting ready to go see his brother, and it's getting late. And I told my husband, I said, you better go get him. We got to get going. I hear my husband go down the hall and knock on the door, and I hear him say, there's no response, this door's locked. And we normally don't lock the doors in our house, so that was a sign right there something bad was happening. And I'm just listening, so I hear my husband again knocking, and he's saying, Austin, and there's no response. My heart sinks because I'm thinking something is not right. I go down the hall, and we manage to get the door open. And at first, all I see is his bed, and it's not made. So I'm thinking, he left. He left the house last night. And then I look, and I see him on the floor in front of his closet. And my husband, we run over there, and he starts, seeing if he's, conscious, and he's not. He starts doing CPR And then I called 911, and then she tells me to start doing mouth-to-mouth. And it seemed like forever before the police got there, but I guess it was pretty quick, and they got there, and he just comes in, and I'm like, do something. And he just looks at me, and he says, he's gone. And I can't even describe to you what that moment was like. My 24-year-old son, who just got his master's degree, who had his whole life ahead of him, I was just talking to a few hours before this, is gone. The worst thing that could ever happen to parents is to lose their child. It's been almost 8 years, and it seems like it just happened. I'm still in touch with his friends, which I can't believe. And it's great to see them, but they're all getting married, they're starting their families, and it's hard for me just a lot of times to see that. Because he's never going to have that. I'm never going to see his children. I'm never going to see the person he might have got married to. So my whole purpose of sharing his story is hopefully prevention. For anybody out there that's thinking about going down this road, I want to stop you from even experimenting, because it will probably kill you. And and that's the truth about fentanyl. What Austin got that night was 100% fentanyl. He thought he was getting heroin. It was 100% fentanyl. He didn't have a chance. He didn't have a chance. Even if I got to him after he did that, he probably wouldn't have survived, because I didn't have Narcan at the time. I'm so glad to hear, about all the programs now that are going on, that, the medicated assistant treatments that people can get now, because after we lost Austin on his phone, we saw that he was looking for Suboxone. So he knew he had a problem. I wish he would have came to us, but he never did. He was never totally honest about what he was doing, ever. And I guess that's part of addiction. His friend said he probably just didn't want to, disappoint you guys. But I told him so many times, I said, the only thing I want is to help you. My point is to any of you guys out there, if you have a loved one or you're friends with somebody that you know is struggling with addiction, you cannot handle this yourself. It's going to be impossible. You need to get them the help that they need. You need to talk to a trusted adult, somebody like Michelle, somebody who can get them the help that they need, because you won't be able to help them. But what I want to say, the stigma is still there. It's still terrible. These are not bad people. These are people who just got addicted. You can say the first time it was a choice, yeah. Who knows they're going to get addicted? Nobody wants to be addicted. So my point of tonight is, hopefully, if you know somebody, please get them help. Please, I am begging you. It's not going to end well. They're either going to die or they're going to go to jail. And either one is not good. And as parents, too, I have to say, I feel like we made a lot of mistakes looking back. I used to always think I was an enabler. We weren't enablers, but in a way we were, because we were in denial about a lot of things. So that's my message for you tonight, and I appreciate you listening to me. And to all you nursing students out there, if they come to you, show them, like Michelle was saying, give them dignity. There are people who are sick. That's it. They're sick and they need our help, like anybody else with any other disease. Thank you.
Would you like a 5-minute break? Okay. We will start back in 5 minutes. Thank you.
conditions that promote healthy behaviors and lifestyles. As you see, proactive and empower are key words in this definition of prevention. Proactive means to create or control a situation by causing something to happen instead of responding after something happens. Empower means to provide the means to achieve something and/or enable to adopt new behavior. Prevention, by its very definition, states that preventive interventions are the present or pre-crisis implementation of strategies that would yield positive outcomes that hopefully change future behaviors. The goal of prevention, it's probably got to change, is to delay the onset of first use. Research indicates that if we can keep young people from engaging in substance use by the age of 19, that the percentage of them engaging or becoming substance use addicted decrease. But recently, we've had drugs that you can't experiment with, that the first time may be deadly. I tell young people that now you can't do what people in my generation did. Now it's like having 5 bullets in a 6-chamber gun and playing Russian roulette. Chances of getting blown away are extreme, are off the charts. So prevention is viewed through the lens of life domains. Each life domain has different challenges that are distinct and unique to that domain. The 5 life domains are school, peer, individual, community or neighborhood, and family. We looked at where prevention is on the substance use continuum. We have defined prevention as it relates to substance use and other negative behaviors. Now we look at how evidence-based programs are implemented. Oh, thank you. The Center for Substance Abuse Prevention is under the auspices of SAMHSA, Substance Abuse and Mental Health Services Administration. They've identified 6 strategies that are used to deliver prevention services. In North Carolina, there are 100 counties, and prevention is taught and implemented in each of those 100 counties. These strategies represent a holistic approach to prevention. The aim of prevention is to prevent initiation of substance use, to delay first use or onset, to prevent progression of substance use, prevent and reduce harms associated with substance use. Now, these 6 strategies are used in most comprehensive prevention planning and implementation. These strategies are information dissemination, alternatives, prevention education, the environmental approach, the community-based process, and problem identification and referral. We'll briefly look at 2 of these strategies, prevention education and information dissemination. Thank you. The prevention education strategy provides information and activities targeted to affect critical life and social skills, including decision-making, refusal skills, and critical analysis. Evidence-based programs are researched and peer-reviewed and have been proven to decrease substance use, violence, gang involvement, and weapons in school among targeted populations. The following is a slide of evidence-based curricula that has been implemented in Gaston County. As you can see, these are examples of evidence-based research programs that are used in the prevention education strategy. These curricula are usually facilitated once a week and are facilitated in schools and in community settings. One of those curricula, this curriculum It's called Prime for Life. It's designed to help participants change their drinking and drug use behavior by examining beliefs, internal motivations, and risk perceptions. Prime for Life is also used for those who have been charged with DUIs in North Carolina. Safe Dates is another curriculum. It examines dating violence as it relates to substance use. Now, all these curricula are targeted to specific populations. There are about 50 or 60 of these, what we call evidence-based curriculum, that change people's lives. They have been researched thoroughly, and they do change lives, but they do not in and of themselves change a person's life. It's not siloed. So the Gas and Controlled Substance Coalition, we have a targeted approach where we connect the dots to make sure everyone has a hand in changing a person's life. And prevention says, let's spend $1 today so we won't have to spend $16 later. Let somebody live today and not transition tomorrow. It's similar to a story that goes around in prevention circles, and you've probably heard it. I have a different spin on it. There's a hill, there's a mountain, and people going up, going to the edge of the mountain and falling over. Just falling over, going to the hospital. Some folks are dying. So somebody says, we got to do something about this. We got to buy more ambulances. We've got to have more doctors, more nurses. We've got to build better hospitals. So people still run up, fall down. Well, things aren't changing. What's going on? And somebody said, how about us building the fence halfway up and stopping folks from getting to the top and falling off? That's prevention. Not as sexy as buying ambulances and building bigger hospitals, but we're about prevention. They say an ounce of prevention is worth a pound of cure. Next slide, please. Now, information dissemination is a strategy that provides information about substance use, substance misuse, about prevention, and we inform the community through one-way communication, much like I'm doing now, through presentations, health fairs, through media efforts, and through outreach events. The information dissemination strategies have been implemented in schools, parks and rec, boys and girls clubs, faith communities, and we cover topics like substance identification, both legal and illegal substances, resiliency skills, problem solving and decision-making skills, conflict resolution, communication, and team building. RHA participates in health fairs to publicize our program, one, and to expand our reach in the community. We have strategically placed billboards around Gaston County, and that addresses evidence-based campaign messages like Talk It Up, Lock It Up, that involves raising awareness among adults about young people having easy access to alcohol at home. We have lock-in medication, campaign billboards that address easy access to medications at home. Research indicates that most young people who get their drugs get them, number one, from their friends, and number two, from home, especially alcohol. These campaigns increase awareness primarily among adults, and we also distribute alcohol bottle locks to lock up alcohol that folks have in their homes, and cabinet locks to lock up your alcohol in a cabinet. We also distribute medication lock boxes. Just talked about young people stealing medication, grandkids visiting their grandparents more often now. So this is a combination medication lockbox that we distribute during medication take-back days that we have periodically in Gaston County. So this basically is prevention. Didn't want to get into statistics. Wanted to talk about prevention and steps that we can take to promote the prevention message. We have 12 people thus far in Gaston County who have taken what we call YPE, Youth Prevention Education, 2-day course from 9 to 1, and they're certified to teach all 50 or 60 evidence-based programs in Gaston County. So if the money goes away, and it ain't getting political, look like it's just rolling away now. When the money goes away, then folks can sustain the outcome and sustain the program. So that's what it's all about, sustainability. Next slide, please. So, I say that prevention is important. It is an intentional, data-driven process that includes national, state, and local data. It is a data-driven process. It ain't, I feel good, I think it should be this. It looked like that worked over here. We take data, we look at data, we analyze data, and there are programs that fit the data scheme. And the local data is better than the national and state data. So it's not just a women or fancy, it's data-driven and evidence-based. Preventive collaborative efforts are essential and more effective when diverse cultures, individuals, and opinions are involved and respected. And lastly, prevention requires a commitment to continue to implement evidence-based programs, policies, and practices that yield positive outcomes regardless of fiscal constraints. Because the money goes away, the outcomes shouldn't go away, the program shouldn't go away. If we're committed to our young people in leading healthy, productive lives, then we have to sow into their lives. My mom and daddy used to tell me, what you sow today, son, you're gonna reap tomorrow. Some shape, form, or fashion, be it positive or negative. So having said that, my brain ain't completely burned out. Been up since 5 o'clock, and I'm old. Duh. I'd like to say thank you. Keep your head up and do what you can do for other folks, because you got to. We're supposed to take care of one another. That's just the way that is. So I'll say good night, and my time is up. Now thank you for yours.
Thank you, Maceo. Our final speaker is Delton Russell. Delton?
Hey, folks. So two things. One, I'm going to walk a little bit while I do this because standing still kind of, hey, don't touch that. Standing still is hard for me. Two, the intention of this for me is to be kind of Socratic in nature. So I'm going to call on you to give me some answers every now and again, right? So whenever I do that, please do me a favor. Don't just stare at me. Actually engage. Because I can tell you, I've worked a lot with, done these trainings a lot over the years, and when you ask people questions and they just stare at you, my body temperature goes up. I'm wearing a sweater. I'm going to start sweating. It's going to be a whole thing. It's going to be ugly for me. It's not going to be fun for you. So let's just engage, shall we? Okay, so I want to... Oh, geez, Louise. I really, guys, this is like a 3-hour training condensed to like 20 minutes. So I'm going to try to hit the highlights and hit the important pieces of it. But the big thing is I want to share with y'all. Dr. Daniel Summert from the University of Tennessee in Knoxville, he's the head of the addiction medicine program there. Some years ago, he said, addiction shouldn't be called addiction, it should be called ritualized comfort seeking. Why would addiction be ritualized comfort seeking? Anybody got any ideas on that? Yes, sir.
I mean, you're being driven to try to seek comfort again and again in the same pattern over and over again.
Yeah. So anybody heard of Gabor Mate? If you haven't, I strongly encourage you to write his name down. It's Gabor Mate with a little apostrophe hanging out over there. He wrote a book called In the Realm of Hungry Ghosts. One of the things that Gabor Mate talks about is he says, we need to stop asking what's wrong with addiction and start asking what's right about addiction. What is addiction doing for a person? What needs is the drug use meeting for the person that they couldn't get otherwise met, right? Okay, so I want to frame everything that we're going to talk about around that. Hey, speaking of Dr. Gabor Mate, look at that. We got a quote by him. He says, ask not why the addiction, but why the pain. This is the question neither the prevailing disease-based medical paradigm nor popular prejudice would even think to ask or yet alone answer, right? So why is this our current paradigm? Anybody got any ideas on that? Yeah, this is where it gets tough, right? So this is our current paradigm because we view addiction as a moral failing. I can tell you that I've known a lot of people that have used drugs over my life, myself included. Good Lord, I'm in recovery longer than some of you have been alive. Well, actually, a lot of you have been alive. Whew, hey, getting old's weird. Anyways, so the point is, just wait, it happens. But anyways, the point that I'm getting at is that in that time, I've never met bad people, but I've certainly met people in bad places, right? Okay. So looking at trauma, we know that 76% of men and 80% of women in active addiction have significant levels of childhood trauma. So anybody know what I'm getting ready to reference? What study? ACEs, Adverse Childhood Experiences Study. Anybody familiar with this? Anybody ever heard of it? So back in 1995, Dr. Fellini, who worked for Kaiser Health Plan, Kaiser Permanente, he was studying morbidly obese people, trying to understand why are morbidly obese people morbidly obese, right? Because as you would expect, being a healthcare plan, those people used up a lot of the resources and cost the healthcare plan a lot of money. So, insurance being what insurance is, they're trying to figure out how to prevent having to spend all this money all the time, right? Very altruistic, noble causes there. Okay, so they're studying people that are morbidly obese, and what they find is they stumble onto the fact that an overwhelming majority of people that struggle with obesity also have significant levels of childhood trauma. Anybody care to guess what the correlation is there? Anybody know what food releases in your brain when you eat it? Dopamine, absolutely. Absolutely. Anybody know what childhood trauma releases in the brain when you experience it? Cortisol. See, we're always doing this dance, right? So really what we're talking about, when we talk about addiction, what we're really saying is that we're talking about cortical modulation. We're talking about the ability to manage the cortisol releases that we're experiencing, right? So we got a high level of cortisol, we solve a problem, what does the cortisol do? It goes down. I always give the example, you ever lost your keys before? What's a feeling you associate with losing your keys? Stress, right? I mean, really, if you look at the definition of stress, more is being asked of you than you have the resources to currently mobilize, right? Literally, that is the definition of losing your keys. Like you're trying to go somewhere and you can't go anywhere because you don't have your keys, right? So that produces stress. Cortisol levels increase. But when you find your keys, what's a feeling you associate with finding your keys? Relief. You notice how all of you said relief? That's a common theme, right? Well, what causes that relief to be felt? When you find your keys, your pleasure reward center in your brain releases dopamine to reward you for finding your keys, so that way you're more likely to find your keys again in the future, right? Yeah. So when you eat highly processed sugary foods in large quantities, what does it release in the brain? Dopamine. So through a Pavlovian classical conditioning, if you will, that becomes a maladaptive coping skill, right? The reason a person uses alcohol or illicit drugs is for the same reason. Also, I'd like to include tobacco in that. So, anyways, as I said, 76% of men, 80% of women in active addiction have a history of abuse. So what does that mean specifically? Anybody know how many ACEs you have to have before we consider that to be a lot? Like what's the number that's the tipping point? Okay. So, experiencing any of the following conditions in a household prior to the age of 18. Recurrent physical abuse, recurrent emotional abuse, contact sexual abuse, an alcohol or drug user in a household, incarcerated household member, family member who is chronically depressed, mentally ill, institutionalized, or suicidal, mother is treated violently, one or no parents, physical neglect, and emotional neglect. So how many of these do we have to answer yes to before we really start to consider this to be a lot? Okay, so two things. One, let's be honest, these are weighted, okay? Meaning that if your parents get divorced, that's going to impact you differently than, say, if you were sexually abused as a child, right? But they also don't typically happen in a vacuum, right? If you're starting to experience the heavier ones, usually the lower ones come along with that. So I say that to say that for educational purposes, an ACE score of 4 is where we start to see significant levels of impairment in a person's life. Now, again, I mentioned previously, this study was done in 1995. And while we thought we were pretty evolved in 1995, maybe we weren't as evolved as we thought we were, right? So there's things that we take into consideration now that we don't count towards points, but they're things that we, like a special consideration, if you will, right? So what does that look like? The revised list includes things like property victimization, peer victimization, non-sibling, because who picks on you more than your siblings? Nobody, right? Okay, so peer victimization, property victimization, non-sibling, we'll call that bullying, right? Exposure to community violence, socioeconomic status. The interesting thing to note about socioeconomic status is when I say socioeconomic status, what's the very first thing that you think of? Poverty, right? But you know, being incredibly wealthy can be crippling as well because it completely skews your perspective of life and how you interface with those around you, right? Someone close had a bad accident or illness, below average grades, parents always arguing, no close friends. So here's the thing that I want to ask all of you. If we were to remove someone close had a bad accident or illness, what do all these things directly impact for a person? And while we're at it, what do all these things directly impact for a person? And we're going to sit here in silence till somebody gives me an answer. Yes? Family's a part of it. Yes. Yes. Thank you. It directly impacts a person's self-esteem. If you look at all these things, they all impact how you feel about what? Yourself. So with that said, got to ask the heavy one, what's the largest barrier to recovery? Yes, of course it's me, but how? Critical thinking or other national deficit, right? Okay. Convincing someone that they're worth saving. I think another way to look at that is convincing someone that they have value as a human being, right? So realistically speaking, Henry Ford, 1927, said, whether you think you can, whether you think you can't, you're in fact probably right. If you don't believe that you can, and I really don't mean to sound like a motivational poster that's hanging up in the break room at the office, but seriously, whether you think you can or whether you think you can't, you're probably right. If you don't believe that you can, then you don't try, and if you don't try, then you fail 100% of the time, right? So when we talk about generational wealth, we're not just talking about money that parents hand down, right? We're also talking about parents handing down a belief system that we're worthy, that we have value, that we're capable of doing more, being more, experiencing more, so on and so forth, right? So, simply put, anybody know the difference between guilt and shame? Guilt's when you feel bad about who you are, guilt's when you feel bad about what you've done. Shame is when you feel bad about who you are, right? Shame directly impacts our internal belief system. So when we experience a high level of shame, that directly impacts how we see ourselves in relationship to the world, right? And think about how that starts to impact our ability to believe in ourselves and our ability to do things, to heal, to grow, to get well, do all those things, right? And my deepest question to you is think about how all these things impact a child experiencing shame. Especially when you're growing up in an environment where not everybody around you is experiencing the exact same thing. When you're the odd man out. Shame's always that thing that like you just don't want anybody to know about. We'll call them skeletons in the closet, right? Okay. So looking at how the ACEs study translates, we see that a person with an ACE score of 4, now mind you, this is just a 4. 4 is not terribly hard to obtain. They have a 250% increased likelihood of contracting hepatitis. They have a 330% increased likelihood of being the victim of sexual assault. A 390% increased likelihood of developing COPD. Certainly, that could not be related to a 1,300% increased likelihood of using tobacco products, right? Person with an ACE score of 4, they have a 1,220% increased likelihood of attempting suicide, of completing suicide. And I want to point out to you that every person that completes suicide, there's 37 other people that have survived an attempt. And I don't want to even dare stick my toe into politics in any capacity, but I will say this should not be a political statement. This is just a fact. As a society, we talk a lot about gun violence. You know that 2/3 of all gun deaths in our country are suicide? How much do you hear about AR-15s versus how much do you hear about suicide? We talk a lot about gun violence. We talk very little about suicide. And then lastly, a 580% increased likelihood of experiencing depression. But how does this relate to the opioid crisis? Well, funny you should ask. A male with an ACE score of 4 has a 1,350% increased likelihood of becoming an IV drug user. Increase that 2 more points, talk about dose response, right? 2 more points, just from a 4 to a 6, that number jumps from 1,350% to 4,600%. Guys, this is just a 6. This isn't even getting into a 10, which is where the ACE score tops out. And I can tell you, having spent a lot of my years working in detox, anecdotally, I can tell you that most men I interface with have an ACE score of 7. Most women I interface with had an ACE score of 9. Very, very commonly. So if you look at probabilities there, a person with an ACE score of 0, 1 in 16 smokes. Person with an ACE score of 7, 1 in 6 smokes. Person with an ACE score of 0, 1 in 480 uses IV drugs. Person with an ACE score of 7, 1 in 30 uses IV drugs. Person with an ACE score of 0, 1 in 96 attempts suicide. Person with an ACE score of 7, 1 in 5 attempts suicide. See, we're not just talking about addiction. We're talking about wellness as a whole. We're talking about eating habits. We're talking about exercise habits. We're talking about tobacco use. We're talking about alcohol use. We're talking about drug use. We're talking about sexual habits. I mean, we're talking about a lot of different things here. It's not just drugs and alcohol. Drugs and alcohol are a huge piece of this, but they're not the only piece of this. So I used to work in the MCO structure, and I didn't know who my boss was going to be from one day to the next because things changed a lot around there. And I really began to love a good flow chart. So I developed a flow chart around the ACE study to help me better explain how and why the ACE study works, right? So You have a person that has high level of ACEs, meaning they have an ACE score of at least 4, if not more. What does that release in the brain? Cortisol, right? So when cortisol gets released, a person's experiencing things like depression, anger, and anxiety. So when you experience things like depression, anger, and anxiety, what do you automatically, biologically, how are we wired as human beings to start looking for? We start looking for that dopamine, right? So where do we find dopamine? We typically find it in places like smoking or using tobacco products, vaping. I should update this, right? 2025, let's be honest. Most people vape, not everybody smokes these days. But anyways, smoking, tobacco use in general, alcohol and drugs, high number of sexual partners, and what do all those things release in the brain? Dopamine. But let me ask you this. That dopamine that those things release in the brain, do they solve the childhood trauma? No. What do? They temporarily mask it, right? So if you think about it like this, cortisol releases go this high, and then dopamine releases go way up here. We're not paying attention to that that cortisol right now, right? But then what happens that dopamine? It recedes back to normal levels, and where's that cortisol? It's right there waiting on us where it's been the entire time, right? Anybody ever had chronic pain or some severe pain that you wind up taking a prescription opiate for? Yeah, works the same damn way, doesn't it? We're experiencing this pain. We take this painkiller. Does the painkiller kill the pain? Nope, it masks it. And then when that painkiller wears off, where's that pain? Right there waiting on us where it's been the whole time. And this gets even more complicated when we look at the fact that 90% of people that experience addiction started using before the age of 18. The brains aren't done developing yet. So here we have people that have trauma. They've got genetics, which that's a whole other thing that I don't have time to get into. But we've got genetics, and then we also have the fact that they started using before the age of 18. Anybody know what that causes in the brain? You ever heard of Arrested Development? Not the band nor the TV show. Arrested Development means whatever age you started getting high at, that's the age you stopped developing coping skills. So you might be a 45-year-old man with a wife, kid, a house, dog, and a car, but you've got the coping skills more like that of a 13, 14-year-old child. Cortical modulation, right? Cortical modulation is how we deal with stress. How do we modulate cortisol? How do we handle that cortisol, right? So going back to my slide here. So when I engage in things like smoking, tobacco use, drugs, alcohol, sexual partners, what have you, that releases a high level of dopamine in my brain. That level of dopamine creates mood regulation, but that mood regulation only lasts for so long, and then I'm back to feeling depression, anger, and anxiety. So what do? I do it all over again, right? And I just keep doing it all over again. Anybody remember Pavlov? So what happens when you get a treat with repetition? Your brain starts to associate that thing with this thing, right? Classical conditioning. So what happens is we wind up experiencing addiction. That's what we'll call chronic use. And what does chronic use lead us to? It leads us to disease or early death. I always give the example, my father started smoking when he was 13. Was he thinking about lung cancer at 13? Of course not. Was he thinking about lung cancer at 23? Nope, because this was the 70s. Was he thinking about lung cancer at 33? Nope, because this was the 80s. Did he think about lung cancer at 43? Maybe just a little bit, but he died of lung cancer at 49. And what I'm getting at is that we often start doing things, to Macio's point that he was talking about before, we start doing things at an age before we start to have any concept or understanding of the consequences and how those things are going to impact us long term, right? And as a byproduct of that, we become victim of our circumstances. Folks, that's my contact information. If I can be of service to you or anyone you know, please do not hesitate to reach out to me anytime. If you have any questions, please feel free to ask. And also, I want to be clear with you. You can ask me anything that you like. If you offended me, you got up very early this morning and put a considerable amount of effort into it, so no worries about that. I'm very laissez-faire and easy peasy, so anybody? Bill's throwing the shepherd hook on me. Appreciate you, brother.
Thank you. I wanted to focus on what Michelle said earlier. What are we going to do when we leave here tonight? And I felt this august body represented a true picture of what we're all facing. So tonight, I owe all of this to the nurses, both at Caramont, Belmont Abbey, and also at Gaston. I don't know a finer group of people that have done and worked as hard to bring this together. I also owe this to the Rotary Foundation, to the Rotary. I have the District Governor, Kevin Kendrick, right here. And this event has been sponsored by the Gaston County Rotary Clubs. So I hope to make it something annually, and I hope to bring the focus here that we continually shine the spotlight. And I want this to be a Gaston County, the whole effort. So why don't you come on up? I want to introduce you. This is a Abbey student. He's a senior, and he's president of the Rotaract Club of Belmont Abbey.
Thank you. Hey guys, the slide right here, I handed out a couple of those cards. If you didn't get one, they're right on the nursing table right out front. That first number right there is the North Carolina Crisis Hotline. That second one's going to be the North Carolina Mental Health Hotline. The last one is the North Carolina Suicide and Crisis Hotline. If you guys are having any trouble and you can't find anyone to talk to, call those numbers. They are trained to help you out, and they want to reach out and just make sure you guys are okay. That QR code, if you scan it, it's going to bring you right to the scheduling for the Abbey counseling service. If no one has been to the Abbey counseling service, they are amazing people. They're so easy to talk to. I've been there multiple times. They're fantastic. It's free for us as Abbey students. Take advantage of that, because all I've heard is therapy is extremely expensive. So right now we got that advantage of taking for free. Use it. I always recommend that you should go once a year just to talk out your feelings and see what's going on. But besides that, I do have a little personal story for you. When I was 14 and 15, I was actually addicted to Xanax, and it started off so easily. My mom, my dad, my sister, and me all have trouble sleeping. Just something that we have always had trouble doing. So my dad and my sister both have prescriptions to Xanax, and one day my dad gave me just a tiny sliver of a 2 milligram Xanax just to help me sleep at night, and it worked. It really did. And whenever I had trouble speaking, I would trouble sleeping. Sorry, I would take a little bit and go to sleep. But one night I took one, and I decided to stay up, and I felt extremely confident. I never felt so good in my own body, and I just felt amazing, just as me. And that was just really good to see, just to feel that in that moment. So when he would leave for work or something, I would go and I'd take a couple pills myself, and I would keep them, and I would just hold them and just until I wanted to use them again. And one day, I remember I was going to meet my friends at a park. I decided to take 3 2 milligram Xanax to go meet with them. That doesn't seem like a lot, but it is. And I was there with them, and then we went to my friend's basement for a little bit. And it was probably about 9:30, 10 p.m. All the lights are on. We're all wide awake, just enjoying our time as boys playing around in the basement. And I decided that I was tired and I wanted to lay down. I just laid down on the floor, and I guess I fell asleep, but my eyes were wide awake, and they couldn't even tell if I was breathing or not. And they're 14, 15 too. They're scared. They don't know what to do in that moment. So they're smacking me across the face as hard as they can for about 5 to 10 minutes, throwing water on me, just throwing me around, trying to wake me up. And they couldn't for a little bit, and then they finally were able to. Luckily, I was able to wake up in that moment, but when I did wake up, I noticed how scared, how worried they were, and it just hurt me because these people truly care for me, and I'm putting them through that. And I just couldn't imagine doing that again, but luckily I had those group of friends around me in that moment, so after that, they were able to help me stay away from those pills and just to stay clean, and whenever I was having trouble or anything like that, I could always call them. I can always talk to them. So I was very lucky to have them. So if you guys are going through anything, I just want to advise, please call those numbers. Go to the counseling service. Talk to anyone that you feel comfortable with talking with. If it's a friend, a family member, a teammate, a coach, a professor, anything. Anyone will listen to you. The counseling service, they are amazing people. They will listen to you. They're very great people. Like, just anything you can talk to, and when you feel trusted with, talk to them. If you don't trust any of them, like, I'm more than happy to listen to you guys. Just please, like, you can see me around campus, you can see me after this, like, please just talk to anyone, because you never know what someone's going through or what they're doing until it's too late. So I just want you guys to just be comfortable with talking through this, because it's not okay until it just really isn't okay. Thank you guys.
So we've come to the point in our program where you probably want to go home and you probably want to ask questions. So does anyone have any questions you'd like to ask of our speakers who are here on the panel? I'm not going to get paid if no one asks a question. But we can get those numbers. The state compiles emergency department numbers year to date showing opioid overdose, people with opioid overdoses who are brought to the ED by the source of the drug that caused them to have the overdose and their disposition, whether they died or not. And we can get that to Whitney and through Whitney to the college. You had a question. So what to do when nurses encounter people with opioid use disorder? Yeah.
Treat them just like you would anyone else, with love and compassion, and call them by name. We treat the person as a person, and the disease as a disease. If you refer, and you heard me say earlier, I don't call anyone an addict. If I do that, I'm treating their disease before I'm treating their humanity. So that's what I would encourage you to do. Be aware. Educate yourself, so that way you know what's in the community and what resources can be offered. And work with case managers, but do it in a way and work with case managers who have people's best interests at heart and aren't trying to clear their caseload. And that's just being real for real. But above all else, compassion.
I would also say, my input, people forget what you said, people forget what you did, but they never forget. Treat people like they're human beings, like they're somebody you know and love.
For the person who asked about the numbers and opioid deaths, I would encourage you all, as nursing students, to do your own research. Go to Google the opioid, North Carolina opioid dashboard. The Centers for Disease Control Prevention. The Community Health Assessment, which is local, and I think this year, 2025, they'll be doing a new assessment. Monitoring the future, we look at long-term substance use and local trends. And the other is the LNEMC partners telephone survey. So all partners will tell you some statistics and data, not only opioids, but marijuana, cocaine, heroin, which is making a comeback, shifting from fentanyl to heroin.
I'm almost done, but thanks anyways. but anyways, I just say, like, seriously, ask people, what happened to them, not what's wrong.
Chief, was that you that asked about the overdose deaths? So I'm pulling the state data that came out today. And understand, and this is good for those of you who want to look up and keep up with the opioid dashboard, which is linked through the opioid settlement webpage through the county, but it is also available through the Injury and Violent Prevention Branch at the state level of DHHS. Understand when you're looking at these numbers, what is reported out each month are ED visits by diagnosis, and those vary widely depending on what the primary cause is, correct, when they come in. So that could be a challenge. But the other thing is with overdose deaths, it can take up to a year for someone's death to be confirmed as an overdose, depending on the drug, depending on the other circumstances that are involved. So these are suspected overdose deaths. In 2023, it was 303 in North Carolina. In 2024, as of the end of December, it was 220. So that is a significant decrease of 27%. We do not have the data yet for this year, since we're only 1 month in.
I want to leave on a more positive note. We're going to begin a committee to offer scholarship to memory of Austin, and we'll be working on that committee over the next year. But I felt that was the least we could do, and it would be an important step in recognizing at this community what we're trying to do. Thank you.
Thank you again for joining us this evening. If you have any questions that you'd like to ask of us individually, please come forward. Otherwise, have a safe return home. And again, thank you for joining us. Good night.